Hello and welcome to a recording on neonatology. This is going to be covering all the kind of neonatology elements of the paediatric unit. We'll start off by talking about APGAR scoring. So APGAR scoring, even though they're unlikely to ask you to come up with the APGAR score in the USMLE, they will give you the APGAR scores usually in the question stem. But this is really helpful for your pediatric neonatology rotations especially. So the APGAR score is a rapid scoring system that helps evaluate the need for neonatal resuscitation. That's mainly what this is doing. So just because an APGAR score is normal, it doesn't mean that there's no problems with the neonate. This is purely to tell us about whether we need to do resus or not. It essentially is monitoring 5 different parameters, which can be remembered by the mnemonic of APGAR, even though the APGAR score wasn't made based on a mnemonic has been made from it. And each facet is scored from 0 to 2, and you'll get a score out of 10, and this will be done at 1 and 5 minutes after birth. So let's quickly go through it. The first A is activity, i.e. muscle tone. You get 2 points if there's active movements of the baby, of the neonate, okay? If the baby is moving, but they're only really moving and they only really have tone with flexion of the arms and the legs, this is 1 point. And if there's absent muscle tone, this is 0 points. The P in APGAR you can remember by pulse. So if it's above 100 beats per minute, this is great, this is 2 points. Do remember that the heart rate is a lot higher in neonates than it is in adults, so you're expecting a heart rate of above 100. And if it's less than 100, we have 1 point. If it's 0 points, it means there's absent pulse. The next one is grimace. So grimace is essentially looking at the reflexes and the irritability and the movement as a whole. If the baby's active, i.e. they're sneezing, they're coughing, they're pulling away, they're reacting to their environment somewhat, they get 2 points. If there's just some flexion of the extremities, this is 1 point. And if there's flaccid sort of tone on the baby, then this is 0. So a lot of the time, the activity in grimace will have links to them, okay? The second A is appearance, so skin color. So fetuses, when they're born as babies, they should be pink all over, okay? So that would be scored on 2 points. If they have cyanotic or pallor in the extremities, this gives them 1 point. And if they're diffusely pallor or diffusely cyanosed, this is 0 points. Then in terms of respirations, this is how good is the patient's respiratory drive and their ability to essentially exhale and inhale. If they're able to vigorously cry, then this shows that they've got good muscles of breathing, so they get 2 points. If they have slow and irregular respirations, maybe this is 1 point, and if there's absent respirations, this is 0 points. So from your APGAR score, you can essentially decide whether this patient needs immediate attention and cardiopulmonary resuscitation. If they're scoring between 8 to 10, this is usually reflecting a good cardiopulmonary adaptation and they don't need any resuscitation. If they are scoring 4 to 7, this is our in-between, okay? These patients should be observed and they may need ventilation, okay? And then unfortunately, your 0 to 3, this is indicating something majorly wrong. They need immediate resuscitation. So now let's discuss some congenital malformations. We're going to be looking at choanal atresias, Vactal-based syndromes like tracheoesophageal fistulas, amongst many other things, okay? So we'll start off with the choanal atresia. Choanal atresia is essentially an occlusion in the nasal choanae, okay? And this, if I was to sort of draw it, this is, let's say, the nose. This is then a very inaccurate nasal cavity. Usually, we have patency of this specific area, because then that will then lead on and be continuous with the oropharynx down here. In a choanal atresia, one side or both sides is essentially occluded, okay? This can either be a bony occlusion or it can be a soft tissue occlusion, or it can be both. And in most cases, we're usually talking about both. Okay, so that's what a choanal atresia is. It usually presents, if unilateral, as chronic recurrent purulent nasal discharge. Okay, but that's if it's unilateral, which is just an obstruction of one side. If it's bilateral, the patient is unable to breathe properly. Okay, they're unable to breathe through their nose. Okay, and this is considered a neonatal ENT emergency because when the baby feeds, the only way they can breathe is through their nose. So while they're feeding, they're unable to breathe through their nose and they can start choking, they can start having cyanosis. It can be associated with the very famous CHARGE syndrome, which is not really a syndrome, it's more of an association disorder. But CHARGE stands for coloboma, heart disease, atresia of the choanae, retarded growth and retarded mental development, genital hyperplasia, and ear abnormalities, okay? So essentially what this means is that patients with colobomas and maybe retarded growth are also at increased risk of having a choanal atresia as part of that. So these are just associated diseases. How do we diagnose CHARGE syndrome? Well, we would start off by doing a CT scan, and that will show usually an enlargement of the voma. But the actual proper way to diagnose this, the diagnostic test, is doing a flexible nasal endoscopy, and that will just show your point of obstruction. Regarding your treatment, the most important thing, especially if it's bilateral, is to establish oral airway. So making sure that the baby or the neonate is able to breathe sufficiently. Then once we've done that, we can then start to consider surgical nasal repair and potentially even stenting. Okay. Let's talk now about the tracheoesophageal fistula. The tracheoesophageal fistula is essentially a connection between the trachea and the esophagus. Okay, and there are many variations of this specific congenital malformation, but the most common is I will draw esophagus in red and trachea and airway in blue. So the proximal esophagus ends in a atresia, and then the distal esophagus links on with the trachea. Okay, this is the most common variation of the tracheoesophageal fistula, a distal fistula of the trachea and the esophagus. We can have different variations as well. We can have a proximal fistula instead and a distal atresia. Okay, so it can look instead a little bit like this. Or we can also have something called H anomaly, the H anomaly, which is where we have the trachea and then an esophagus which has no atresia but still has a fistula with the trachea. And as you can see, this looks like the letter H. Okay, so you can have lots of different variations, but very important to know that this is the main one that we see. And when we look at the signs and symptoms, they usually relate to this type rather than the others. So just like choanal atresia is associated with CHARGE syndrome, tracheoesophageal fistulas are associated with Vactel syndrome. Vactel syndrome stands for vertebral abnormalities, anal abnormalities, cardiac problems, tracheoesophageal fistulas, renal problems like renal aplasia, and limb problems as well. Okay, and this has a tendency to cause polyhydramnios in utero. Why polyhydramnios in utero? Because polyhydramnios is, in this case, is due to an inability of the fetus to take in the amniotic fluid. Remember, the main way that we decrease amniotic fluid is by the fetus essentially swallowing it. So if the patient isn't able to swallow amniotic fluid because there's literally an atresia of the esophagus, that's going to cause my polyhydramnios. Increased oral secretions, again for the same reason. Inability to feed. Why? Because we have a proximal atresia of the esophagus. Gagging, and an aspiration pneumonia as well. Okay, potentially aspiration pneumonia. Why could this cause aspiration pneumonia? Because we can have gastric content going into the airway, or we can have food, when the baby does feed, going directly into the airway. So it depends which one we have. Also, I just want to note something. When we do an x-ray, if we have this type of malformation, the baby is going to have an increased gas inside the stomach because we literally have a connection between the airway and the stomach. But if we have this kind of association, we have a distal atresia of the esophagus. So actually this patient will have no gastric bubble. So depending on which malformation type we have, the clinical picture will be different. But if you see a case of tracheoesophageal fistula, assume it's this type until you prove otherwise, okay? So in terms of our diagnosis, we're going to do a chest x-ray first, okay? And there's a very, very famous sign where we see a coiling of the NG tube. So let's just say we have our proximal esophageal atresia, which is the most common type. If we pass the NG tube down, that's going to be passed down and then it's going to coil up like this, okay? It's going to coil up. So this is actually a radiological finding that is seen, okay? So it's the NG tube coiling in the proximal atretic portion of the esophagus, okay? And this is identifying the esophageal atresia. Also presence of air in the GI tract, and this is again suggestive of this type of malformation, okay? And you can confirm that with a bronchoscopy. And main treatment is surgical correction. Let's talk now about the congenital diaphragmatic hernia. So a congenital diaphragmatic hernia is where we have GI tract segments protruding through the diaphragm into the thorax. And most of the time this is due to a Bogdalek herniation, which is in the posterior left portion. So say this is the diaphragm, it's looking down on the diaphragm, this is the anterior portion, this is the posterior portion. The Bogdalek is usually a herniation in the posterior left portion. Okay, and what does that mean? That means we're going to have parts of the colon, parts of the intestines, potentially even abdominal visceral organs like the liver, herniating into the thorax and causing problems during fetal development. The main problem we get is respiratory distress, and this is due to pulmonary hyperplasia. So when the fetus is developing, if we have herniation of gastric content into the thorax, this is going to compress the airspace, and it means that we don't have full maturation and proliferation and development of the airway. So we get pulmonary hyperplasia and pulmonary hypertension. We can get a sunken abdomen, okay? This is also called a scaphoid abdomen, and this is because a lot of the abdominal content will be in the thorax, so the abdomen looks sunken. And you're also going to see bowel sounds on the left side of the hemithorax. As I've said already, if we have GI content coming out on the left side, we're going to hear bowel sounds when we auscultate the left side of the chest. Also, the herniation of these bowel contents can push the heart to the right side. So the heart's auscultative findings are usually going to be louder on the right. Okay, so keep that in mind. The first investigation we should be doing is an ultrasound in utero, of course, and that should be finding that there's something wrong, okay? But we can also do a postnatal chest x-ray, and usually we can see bowel content herniating through, we can see mediastinal shifting. But something that they haven't mentioned here, one of the best tests, it's not needed, but one of the best tests is an MRI, okay? Because with the MRI, I can see exactly which abdominal content have herniated through the diaphragm. And this is important because if the liver is herniated, this is a sign of poor prognosis, okay? So that's one of the benefits of doing an MRI. Regarding treatment, we can do high frequency ventilation and also extracorporeal membrane oxygenation. And this is just purely to manage the pulmonary hypertension, which is the main problem. Generally, when we talk about congenital diaphragmatic hernias, what's going to be killing this fetus or baby, unfortunately, is going to be the pulmonary hypertension, hyperplasia and pulmonary hypertension, okay? And then if the fetus and baby does survive, we can do surgical correction. Excellent, moving on now. So we're going to discuss gastroschisis and omphalocele. So gastroschisis, what is it? It's a herniation of intestines only through the abdominal wall, usually next to the umbilicus on the right of the umbilicus, okay? It's got no sac surrounding it, so the GI tract is completely exposed, and gastroschisis is most commonly associated with oligohydramnios and also fetal growth restriction as a result, and even prematurity. There is some studies that suggest gastroschisis has a relationship with polyhydramnios, i.e. an increased amniotic fluid, but I would definitely for your boards remember oligohydramnios as the association more so. It's also associated with other GI malformations such as GI stenosis, GI atresia, and usually on presentation you see this erythematous matted bowel. So for example, if this is the sort of chest of the neonate, these are the nipples, this is the umbilicus, usually you're going to be seeing the herniated bowels out of the abdominal wall to the right of the umbilicus. And because the amniotic fluid will be completely exposing this specific intestine, amniotic fluid is toxic to intestines. So this intestine will be red and matted because it's just been exposed to the toxic nature of the amniotic fluid. Okay. The diagnosis is purely clinical. I think it's obvious why. I mean, if you see this on a fetus or an ultrasound prenatally, then it's fairly self-explanatory. It's clinical. In terms of treatment, the main aim of the treatment is to kind of protect the exposed bowel until you can surgically correct it. So you should be wrapping the exposed bowel with saline soaked gauze and securing it with a plastic bag almost immediately after birth. Okay? And then you've got to be doing surgical correction. If we can't do surgical correction immediately, we can put something called a silo bag over and then gradually reduce the bowel content back into the abdomen until you can do a proper surgery. Okay? Let's talk about the omphalocele now. So omphalocele is essentially a herniation of abdominal viscera through the abdominal wall, but this time it's at the umbilicus, okay? And this time it's covered by a sac. That sac being the peritoneum and an amniotic membrane, okay? And that's why you can see the abdominal content is covered in a sac. This time we more commonly see polyhydramnios in the utero, and again it's associated with prematurity and other GI and cardiac defects. And a high yield thing about omphalocele is that it is associated with Beckwith-Wiedemann syndrome, okay? So look out for your macroglossia, Wilms tumor, ear pitting, enlargement of other organs, but also other trisomies, especially trisomies 13 and 18, your Patau and Edwards syndrome, okay? So gastroschisis is not so associated with other syndromes, whereas omphalocele is associated with other syndromes. The diagnosis, just like gastroschisis, is clinical, okay? You're literally seeing this on a fetus or a baby. It's fairly obvious what it is. You don't need to do any tests to diagnose this. It's clinical. And then regarding treatment, the main aim of this treatment is to try and prevent the sac from rupturing. So when we've done our prenatal testing and we see a omphalocele on transvaginal ultrasound, we will schedule a cesarean section because this is going to reduce the risk of sac rupture. If the sac is intact, then we postpone surgical correction until we fully resuscitated this patient. We're going to be trying to keep the sac covered, keep the sac stable, and we should give petroleum and gauze over it. Okay, so the main thing is trying to keep the sac stable until we've done resuscitation, and then we're going to be doing surgical correction. We can also do intermittent NG suction. The reason is to try and prevent abdominal distension, which can also rupture the sac. Let's discuss now about our duodenal atresia. Duodenal atresia is due to a complete or partial failure of the duodenum lumen to recanalize. So usually during embryological development of the duodenum, there's a physiological, i.e. a normal process that happens where the lumen of the duodenum proliferates and it completely blocks the lumen. This is normal. But then around weeks 8 and 10, this recanalizes to open up the lumen again. And duodenal atresia is essentially where I don't recanalize, okay? This is obviously going to cause polyhydramnios, okay? As I said before, one of the main ways we get rid of amniotic fluid is by the fetus swallowing the amniotic fluid. So if I have an atresia of the duodenum, the fetus cannot swallow that amniotic fluid, so we get polyhydramnios. And then, hours after birth, we get bullous emesis. And this is really important because this is a big differential diagnosis against a pyloric stenosis. Duodenal atresias have bullous emesis hours after feeding, okay? Whereas a pyloric stenosis has non-bullous emesis usually weeks after birth. Duodenal atresias is very associated with Down syndrome and other cardiac GI abnormalities such as the annular pancreas, okay? Annular pancreas is where the head of the pancreas and the annulus of the pancreas wrap around the duodenum and cause an obstruction of the duodenum. Also associated with malrotation and imperforate anus. If you suspect duodenal atresia, your first imaging will be to do an X-ray. With the X-ray, you can see the double bubble sign where the stomach is inflated and the distal duodenum after the atresia is also inflated as well. But you can see the area of the atresia with the inflation either side. And treatment's very simple, just surgical correction. We do have a rarer brother of duodenal atresia, which is the jejunal atresia. Jejunal atresia is not due to a failure to recanalize, it's due to a vascular accident that happens in utero, okay, which prevents the canalization of the jejunum. What happens is that usually it's seen when a mother takes cocaine or other vasoconstrictive substances, so you can use your pharmacology knowledge to apply that. But anything that essentially causes vasoconstriction causes an ischemia to the jejunum, and that then causes a failure to canalize. On examination, we get a really cool finding called the triple bubble sign, where we get a dilated stomach, an isolated dilated duodenum, and then the proximal jejunum being dilated, okay, and that's triple bubble. And treatment is, of course, surgical correction. We do have many different types of jejunal atresia, but the most common type is where we have proximal jejunum, which is completely normal. We have the vascular accident that maybe occurs here, and then we get an orange peel atrophying of the distal jejunum, okay? So this is what happens here. And that orange peel appearance is something that the USMLE likes to bring up. So just a couple of key facts now. Omphalocele, okay, we've discussed this. This can be associated with other congenital abnormalities, which we mentioned. We discussed Beckwith-Wiedemann, trisomies 13 and 18, but it's important to know that gastroschisis is not associated with these congenital abnormalities. Another key fact, and this is just to help you remember which is the gastroschisis, which is the omphalocele. Gastroschisis, you can just remember the letter G, okay? Whereas omphalocele, you can remember the letter O. So gastroschisis, you can remember that the GI content is able to escape the peritoneal covering, whereas in omphalocele, the GI content is contained within the peritoneal covering, okay? So if you forget it, you can just remember gastroschisis and omphalocele. But if you have done step 1, this is going to be, I'm sure, easy peasy for you. You will easily be able to distinguish the differences, so this might not be so helpful at this stage. So now we're going to come on to neonatal jaundice. So neonatal jaundice, by definition, is an elevated serum bilirubin concentration, usually above 5 millimeters per deciliter. And there's two different sort of categories that we put it into. It can either be due to an increased hemolysis, releasing an increased unconjugated bilirubin, or it can be due to a decreased excretion, okay? And when we talk about the other two kind of ways we can categorize it, we discuss conjugated hyperbilirubinemia, which is always pathological, and unconjugated hyperbilirubinemia, which can sometimes be physiological, but also can be pathological as well. If you think about it, physiological jaundice is due to a variety of different reasons, but the main reasons is that neonates have got a very weak bacteria flora, and usually your bacteria breaks down bilirubin. So if you have a weak flora, you don't break down bilirubin as much. Bilirubin gets absorbed from the intestines more, and that's going to increase your enterohepatic circulation of bilirubin, okay? Also, naturally the fetus has quite a high red blood cell concentration. Their hemoglobin is usually quite high, and when they're born, that drops. So they have this kind of surplus of red blood cells which need to be broken down. So that also is going to increase unconjugated bilirubin because of the breakdown of hemoglobin. So these are the main two reasons that we have physiological jaundice. So this kind of brings me on to my next point. How do we differentiate what's a physiological and a normal jaundice, and what's a pathological jaundice that I should be going, oh, we need to investigate this more? Well, firstly, physiological jaundice will never be present in the first 24 hours of life. As I said, it's due to poor flora and an increased breakdown of red blood cells. This takes time after birth to actually come into fruition, and it's usually going to resolve within 2 to 3 weeks after birth. Bilirubin is never going to increase more than 5 millimeters per deciliter a day. Bilirubin's never going to peak more than 14 to 15 milligrams per deciliter. And the direct bilirubin will never be more than 10% of total. Remember, direct bilirubin, i.e. your conjugated bilirubin, if that's high, it's pathological. So what are some of the red flags that tell me that this bilirubin is pathological? If it's present in the first 24 hours of life or at birth, this is telling me that there was an underlying problem happening in utero, okay? If the bilirubin increases more than 5 milligrams per deciliter a day, if the bilirubin peaks more than 50 milligrams per deciliter, if the bilirubin, the direct conjugated bilirubin, is more than 10% of the total, this is pathological, and if it persists beyond 2 to 3 weeks to a month, okay? These are the red flags that should be telling me that this is pathological jaundice. And then this is just a nice sort of diagram just to sort of summarize the findings that we've mentioned. So in terms of the unconjugated causes, we will discuss breastfeeding jaundice and breast milk jaundice. These are two different diseases, but I will be discussing these in detail. Maybe we have an impaired conjugation problem. That could be Crigler-Najjar syndrome. This could be Gilbert syndrome. Maybe we have an increased bilirubin production. Maybe the patient has hemolysis. Maybe they have alpha thalassemia. Maybe they even have sickle cell disease, okay? And then we have our conjugated bilirubins. Maybe we have a biliary obstruction. In neonates, this is most notably your biliary atresia, okay? But it can also be due to choledococceles as well. Or maybe it's an impaired uptake or secretion. We're mainly talking about maybe Dubin-Johnson or Rotor syndrome here. So when we talk about bilirubin in neonates, it's so important to talk about a dangerous disorder called kernicterus. So kernicterus is a complication of unconjugated hyperbilirubinemia that results from irreversible bilirubin, unconjugated bilirubin deposition in the basal ganglia, the pons, and the cerebellum. It typically occurs when the levels of unconjugated bilirubin are around 25 to 30 or above, and it can be fatal. And risk factors include prematurity, asphyxia, and sepsis. Just a high yield pharmacological association is something to do with sulfonamide antibiotics, okay? So sulfonamide antibiotics. Usually we do not give sulfonamide antibiotics in neonates. The reason is because this specific antibiotic displaces unconjugated bilirubin off of albumin, okay? So the blue represents albumin, and the sulfonamide is going to come along and displace the unconjugated bilirubin, represented in green, off of the albumin. And that can then predispose kernicterus, okay? Just a little mnemonic to help you remember Crigler-Najjar, Gilbert's, Rotor's, and Dubin-Johnson. So Crigler-Najjar syndrome and Gilbert syndrome, these are problems with conjugation of bilirubin, okay? Specifically a problem with the UGT1A1 enzyme, which is the main conjugating enzyme. Whereas Dubin-Johnson and Rotor syndrome, they have a defective door for secretion of bilirubin. Okay, so that's just a nice mnemonic to remember. So Crigler-Najjar and Gilbert syndrome, we do discuss these more in the GI unit that I've recorded. And I've also recorded about Dubin-Johnson and Rotor as well. But Crigler-Najjar is the most severe type. This is usually due to a heavily defective conjugating enzyme, whereas Gilbert syndrome is usually seen in adults, okay? And this is just a downregulation of the enzyme, okay? So it's usually a downregulation of the UGT1A1 enzyme. So these patients just have a mildly decreased activity of the conjugating enzyme. And these patients usually only have jaundice and high unconjugated bilirubin in times of stress, menstruation, infection, trauma, etc. So you're not going to be seeing Gilbert syndrome in neonates. Crigler-Najjar syndrome, however, this is due to a heavily defective conjugating enzyme, and you will see this in neonates. Whereas Rotor syndrome and Dubin-Johnson, these are problems with excreting. So these are going to have high conjugated bilirubin. So just a key fact now, I just want to discuss about two important diseases, or symptoms anyway, breast milk jaundice and breastfeeding jaundice, okay? I'm not going to read through this text because this text is a little bit confusing, but breast milk jaundice is essentially something that happens slightly later on, and it's that breast milk has some proteins in it that essentially downregulates and inhibits the conjugating enzyme. So breast milk jaundice is essentially going to cause a downregulation of conjugation of bilirubin. So these patients get an increase in unconjugated bilirubin. Breastfeeding jaundice, on the other hand, is seen usually in the first week of breastfeeding, the first week of pregnancy. And it's actually due to low breastfeeding, okay? It's due to women who do not breastfeed enough. And essentially what breastfeeding does, breastfeeding helps decrease bilirubin absorption in the neonate's intestines. So if we don't breastfeed enough, the baby will absorb more bilirubin and they will get breastfeeding jaundice, okay? So breastfeeding jaundice is due to inadequate milk breastfeeding, and therefore we increase the enterohepatic circulation, okay? Whereas breast milk jaundice usually happens slightly later, maybe in the second week of life rather than the first week of life, and it's due to a downregulation in conjugation, okay? A decreased conj. The treatment of breastfeeding jaundice is hydration, okay? Whereas breast milk jaundice does not require any treatment and it will resolve itself, okay? So two diseases, very similar presentation, very similar time frame, two different pathological mechanisms, and they kind of contradict each other a little bit. Breast milk jaundice is due to breast milk causing bilirubin, high bilirubin, whereas breastfeeding is not enough breast milk causing high bilirubin, okay? So that's quite a difficult concept, but I hope that makes a little bit more sense. So now we're going to talk about the history and sort of physical examination of different types of neonatal jaundice. So if the mechanism is high bilirubin production, this is usually due to an increase in hemolysis, okay? What could be some of the causes of hemolysis? Maybe it's due to an ABO incompatibility or a rhesus incompatibility. Maybe it's due to enzyme deficiencies within the red blood cells. This could be glucose 6-phosphate dehydrogenase deficiency, okay? I've discussed this in a lot more detail in hematology, so please have a look at those videos to get details on that. or pyruvate kinase deficiency. Maybe it's due to erythrocyte structural defects, sickle cell anemia, hereditary spherocytosis. Maybe it's due to an ineffective erythropoiesis. Maybe we're looking at things like alpha thalassemia. Just always bear in mind, patients with beta thalassemia are not going to get signs and symptoms of jaundice until at least 4 to 6 months, because that's when the fetal hemoglobin is decreased and the adult hemoglobin that contains beta subunits is then more predominant. And maybe even babies with sepsis and DIC as well. And these patients will have an increase in conjugated bilirubin. Let's talk now about if we have an impairment of conjugation of bilirubin. We've discussed these already. Maybe it's due to Gilbert syndrome or Crigler-Najjar syndrome. Gilbert syndrome being a mild decrease in conjugation, Crigler-Najjar being a more severe defect in conjugation. Or maybe it's due to the physiological jaundice. One thing I didn't mention before is that babies tend to have a very slow conjugating enzyme, okay? Their enzymes are not working as effectively. So this also contributes to that physiological jaundice. These again have an increase in unconjugated bilirubin. What about if it's due to an impaired bilirubin uptake or an impaired secretion from the liver? Okay, so the hepatocytes are not taking up the bilirubin or the hepatocytes are not excreting the bilirubin. We've already discussed this, Dubin syndrome and Dubin-Johnson syndrome and Rotar syndrome. But these patients are going to have an increase in conjugated bilirubin, of course. Maybe we have an increase in enterohepatic circulation. This can be induced due to poor feeding or our so-called breastfeeding jaundice, even breast milk jaundice, okay, and even dehydration as well. And these patients have an increase in unconjugated bilirubin. And then finally, maybe it's an obstruction of the biliary tree or a decreased excretion. So this could be due to your choledococele, i.e. your choledoccal cysts. Maybe it's the biliary atresia, or maybe it's Alagille syndrome, okay, which is essentially where we have too few bile ducts. So it's a congenital malformation where we have too few bile ducts. Therefore, we don't have a specific obstruction, but we have inadequate bile drainage because there's not that many ducts to drain it. And this, of course, will be a conjugated bilirubin. Also, something to note, if we have things like biliary atresia, we're also going to have other signs as well related to cholestasis. We're talking about acholic stool, okay? That means pale stool, so the stool will be white, and maybe dark urine as well, okay? Dark urine. So in these kinds of patients, we will see other signs as well. We're going to see signs of cholestasis. When we do have sort of a baby with jaundice, a history should be done, and that should be focusing on the diet, because maybe it's to do with the breast milk. Maybe they're not breastfeeding enough, or maybe they are breastfeeding too much, right? So getting whether it's breast milk or formula. Get an idea for intrauterine drug exposure as well. Also get a family history. Remember all those causes of hemolysis? Maybe we have hereditary spherocytosis in the family. Maybe we have glucose 6-phosphate dehydrogenase deficiency in the family. Maybe we have alpha thalassemia in the family. So get a good family history of all of these things. Physical examination may reveal signs of hepatic or GI dysfunction. Maybe the patient has abdomen distension. Maybe they have a delayed passage of meconium. Maybe they have the acholic stools, which I mentioned, and the dark urine, which are telling me the patient has cholestasis. Maybe there was an intrauterine infection, or maybe there was birth trauma as well. In terms of the cephalohematomas, we're going to be discussing those in a minute, but what happens is that blood can build up in specific areas of the scalp, and when the blood is resorbed, this can then cause an increase in bilirubin. That's why this is mentioned here. Okay, but we'll discuss that in a bit. Always keep your eyes out for kernicterus, okay? Some of the signs of kernicterus will be lethargy, poor feeding, high-pitched cry, hypertonicity, and seizures. If you see anybody with jaundice, any baby with jaundice, and you see these signs, this is a huge alarm bell, do not miss it. Jaundice may follow a cephalopedal progression as bilirubin concentrations increase. So if you've ever been on your pediatrics rotations and you've seen neonates and young babies, infants, you'll often see that physiological jaundice follows a cephalopedal progression. It starts in the head and then it eventually goes to the distal extremities. So how do we diagnose? What's our workup for these patients with jaundice? We want to first see, is it direct or indirect hyperbilirubinemia, okay? Because that's going to be determining what the next things we do. So we want to first determine, is it direct or indirect, conjugated or unconjugated. If it's indirect, we want to do a complete blood count. Why? Because I want to see whether this is a hemolysis problem, whether this is an anemia problem, like the thalassemia, the hereditary spherocytosis kind of things. I also want to order a peripheral blood smear as well, again looking for signs of hemolysis. Maybe you're looking out for your inclusions in the red blood cells that we can see in glucose 6-phosphate dehydrogenase, i.e. the Heinz bodies and bite cells. I also want to do blood typing of the mother and the infant, okay? Because I want to see maybe there was an ABO mismatch that caused hemolysis in utero. I also want to do a Coombs test as well. And of course, bilirubin levels will have been done anyway, but I want to do a Coombs test. Of course, Coombs test will be positive if there's hemolysis due to an ABO mismatch, an autoimmune-based hemolysis. For direct hyperbilirubinemia, you want to be ordering liver function tests and bile acids, and even assess the liver anatomy. You can do a biliary tract assessment via ultrasound. You can even do a HIDA scan, okay, to see whether there's any biliary atresia. And essentially, the reason why you're doing this is because you want to see, is there a problem with the liver, a problem with the liver? Is there a cholestasis problem? Is there a cyst? Is there a biliary atresia? So yeah, okay. A jaundiced neonate who is febrile, hypotensive, and tachypnic needs a sepsis workup and ICU monitoring. And I'm just going to give you a warning now. If you haven't gone through UWorld, there is a UWorld question that's going to trick you and trip you up on that. So please keep this in mind, and hopefully you can get that question correct. Regarding now treatment, it really does depend on the underlying cause, because you're going to be wanting to treat the underlying cause. If the patient's got hemolysis, you're going to want to deal with the specific cause of hemolysis. If the patient's got some kind of conjugated bilirubin due to some form of biliary obstruction, you're going to want to do some surgical intervention. Generally, you're going to be treating unconjugated bilirubin with phototherapy if it's mildly elevated. Phototherapy, essentially, it doesn't exactly conjugate the bilirubin, but it makes the bilirubin more soluble. So it essentially creates an own form of conjugation. So this is reserved for mild unconjugated hyperbilirubinemia. If we have severe elevations of unconjugated hyperbilirubin, we want to be doing an exchange transfusion, okay? General rule of thumb, start phototherapy earlier for preterm infants. Phototherapy is not indicated for conjugated hyperbilirubinemia, and it can lead to skin bronzing, okay? So if a patient has Dubin-Johnson, has cholestasis, do not give phototherapy. Common mistake that us students and doctors make. Excellent. So let's now move on to respiratory distress syndrome. So respiratory distress syndrome, also called NRDS, neonatal respiratory distress syndrome, is the most common cause of respiratory failure in preterm infants. It affects 70% of infants born between 28 to 30 weeks of gestational age, and it was formerly called hyaline membrane disease, which makes so much more sense. I don't know why they changed it. Essentially, it's due to a relative surfactant deficiency, okay? Because surfactant is mainly composed of components like lecithin, okay, and sphingomyelin. And unfortunately, before the age of 30 weeks, 32, 34 weeks, the composition of sphingomyelin to lecithin is not correct, okay? So if you're born premature, the ratios of sphingomyelin to lecithin is not correct to make a good quality surfactant, okay? So this poor quality surfactant will cause poor lung compliance, The alveoli, as a result, collapse, and that causes diffuse atelectasis, okay? Collapse of the alveoli and of the airway. Risk factors include caesarean section, maternal diabetes mellitus, male sex, and second born of twins. The reason why caesarean section is a case, generally speaking, cortisol, the stress hormone, cortisol increases surfactant production, okay? And when a mother undergoes natural labor, that's going to cause a lot of cortisol because she's very stressed, and that's going to boost the surfactant production in the fetus's lungs. So if we do a caesarean section, we actually don't get that spike in cortisol, and that can actually increase the risk of NRDS. In terms of what you're looking at presentation-wise, is you're looking at a neonate presenting in the first 48 to 72 hours of life with a respiratory rate above 60 breaths per minute, hypoxemia, cyanosis, and then signs of neonatal respiratory distress. Such signs are nasal flaring, intercostal retractions, and expiratory grunting, okay? So look out for that. And usually look out for a case where it's a premat, okay? Because it's so much more prevalent in premature babies. Your diagnosis, you're going to be ordering APGARs, okay? For blood count, blood cultures. The main reason you're doing blood cultures is to rule out infections. But it is a clinical diagnosis, okay? So looking at the prematurity element, looking at the respiration efforts of the fetus, but you're going to be confirming this diagnosis with an X-ray, okay? So if you see a patient who has got signs and symptoms of NRDS, they've given you some readings for APGARs and for blood counts, if it says which is the best next step management to help confirm the diagnosis, your answer is going to be an X-ray, okay? So here are just some chest X-ray findings that you can see in different neonatal lung pathology. NRDS, you're going to be seeing a ground glass appearance, air bronchograms, okay, and lack of focal opacities, which can be seen in this picture here. Okay, so you see no focal opacities, it's diffuse, okay. In transient tachypnea of the newborn, is essentially where the neonate does not cough out all of the amniotic fluid. So we retain some of the amniotic fluid in the respiratory tract. This causes the so-called perihilar streaking, which can be seen, can you see just around here? You see these streaking here, okay, and here. And in the interlobular fissures as well. Meconium aspiration, okay, that causes coarse and irregular infiltrates. Maybe you see signs of lung hyperexpansion and even pneumothorax as well. And then congenital pneumonias, you're going to be seeing sort of a non-specific patchy infiltration. Regarding treatment of NRDS, one of the most important things you do is you give CPAP, okay? Giving CPAP is going to provide a continuous airway pressure, and that's going to prevent collapse, okay? If the patient continues to have hypoxemia, respiratory distress, we can consider intubation and mechanical ventilation. We can also administer some artificial surfactant, okay, and that is known to decrease mortality. And in terms of prevention, we can give mothers who are at risk of preterm delivery, you can give them corticosteroids, okay? So 7 days, within the next 7 days, you give corticosteroids, and that's going to be increasing the surfactant production in the neonate. Very, very high yield thing to know is the complications of NRDS. The complications of NRDS kind of split into two different categories. One is due to like the hypoxia that the patient's going to get, and then the other is actually due to the O2 toxicity that is induced because of the treatment that they receive. So when they are treated with CPAP and ventilation, this can cause oxygen toxicity, and that's some of the other complications as well. So they can get a patent ductus arteriosus. This is mainly due to low oxygen saturations, which therefore leave the ductus arteriosus patent. Usually the ductus arteriosus closes when the oxygen saturation increases. Bronchopulmonary dysplasia. which we've discussed in the pulmonological module. Retinopathy of prematurity. So retinopathy of prematurity is essentially due to neovascularization problems. When the retina vessels are growing, they sort of depend on a low oxygen, okay? So in utero, the vessels are going to have fairly low oxygen because it's in utero, the fetus doesn't have lungs that are operating at least. This is going to cause quite a high amount of neovascularization because generally neovascularization increases when there is low O2. And then usually when the fetus is born, the oxygen will start to go up, and that slows down, okay, my neovascularization to a nice controlled neovascularization, okay? So it's nice controlled neovascularization. When we have NRDS, the baby's going to be born, and this is going to cause a very, very sudden drop in O2. So the fetus will get very aberrant neovascularization, okay? The vessels will be proliferating very rapidly because it's going to be drop in O2. But then all of a sudden we're going to be giving the fetus lots of oxygen therapy, therefore we're going to get lots of oxygen, and therefore the vessels are going to become very, very unstimulated, and then they get little vessels branching off. So essentially the retinopathy of prematurity is due to this disbalance in when the fetus should be getting hypoxia and more oxygen. It then causes this problem in neovascularization. The fetus can also get signs of barotrauma from the CPAP, interventricular hemorrhage, which we're going to be talking about next, and even necrotizing enterocolitis as well. Okay, and necrotizing enterocolitis is a very complex pathophysiology, but it's essentially due to an overgrowth of bacteria within the colon. Let's talk now about germinal matrix hemorrhage. So, germinal matrix hemorrhage usually occurs in preterm infants or low birthway infants, and it's due to a fragility of the germinal matrix. So, when we have the ventricles, the lateral ventricles, there is this area just to the side of the lateral ventricles called the germinal matrix, okay? And this germinal matrix is naturally very heavily vascularized. There's lots of vessels here. And this is a really weak wall that separates the ventricles from the germinal matrix, okay? It's a very, very fragile area. And these vessels are very, very close to the area, okay? So what happens is that it's caused by a decrease in cerebral blood flow leading to ischemia and reperfusion injury. So when all of a sudden we get these hypoxia, we're going to be getting a high degree of neovascularization in this area, and we're going to be having a high degree of blood flow to this area. And because this area is so weak, it can then perforate through and bleed into the ventricles, okay? So that causes your interventricular hemorrhage, Okay, so many cases, up to 50%, are asymptomatic, but more severe cases can be characterized by hypertonia, a decreased level of consciousness, seizures, and irregular respirations. Germinal matrix hemorrhage can be diagnosed with a head ultrasound, okay? And management is usually supportive. I want to talk now about apnea of prematurity. And this is really different to meconium aspiration, it's different to NRDS, it's different to transient tachypnea of the newborn. It's its own disease, and you've got to be able to distinguish between them. So apnea of prematurity is an intermittent cessation of respirations for more than 20 seconds in premature infants, less than 37 weeks gestation. And it's essentially due to a immature central respiratory center in the medulla. So essentially the baby is born premature, the medulla is not mature enough to maintain an adequate respiratory rate, so therefore we get areas of apnea, essentially. It affects almost all infants with a gestational age of less than 28, which is obviously incredibly premature, and it presents with episodes of intermittent apnea, bradycardia, and desaturation in a premature infant who is otherwise healthy and healthy in between episodes. If you have a patient with transient tachypnea of the newborn, meconium aspiration, NRDS, they're not going to be completely healthy in between episodes, where in apnea of prematurity, they'll be healthy in between episodes. Diagnosis is clinical, and alternative causes should be ruled out. And treatment usually involves non-invasive ventilation and even methylxanthines such as caffeine, which can stimulate the respiratory drive. And that's actually something that I've never heard of before until reading through first aid. Apnea of prematurity usually resolves with maturity of the respiratory centers in the brain. Now we're going to be moving on to a section of neonatology which I used to get very, very easily confused about, and these are the neonatal extracranial injuries. So these are extracranial injuries of the newborn that occur secondary to instrumentation injury during delivery most of the time. And they're usually involving layers of the head from the outermost to the innermost layers of the scalp, essentially, the extracranial structures, so outside of the cranium. And we're talking about skin, the gallia aponeurosis, i.e. the epicranial aponeurosis, and the periosteum as well. Ignore the dura mater and the arachnoid matter. That's really not relevant to this. We're talking about the skin, the epicranial aponeurosis, and the periosteum. So just to kind of draw it out very briefly for you, we have the skull, i.e. the cranium. On top of the skull, we have a layer called the periosteum, which is essentially just like almost like a membrane over the skull. Over that, we have something called the gallia aponeurosis, okay, which is like a fascia over the periosteum. And over that, we then have the skin, essentially. Okay, so I'll just draw the skin. Okay, and when we talk about extracranial injuries of the newborn, it can be due to a bleed here, here, or here, okay, just above the skull. Okay, so if you know that anatomy, if you know the scalp anatomy, it becomes very, very easy to remember these pathologies, okay? When we talk about subdurals, epidurals, subarachnoids, these are all deeper of the skull. So all of these pathologies are above or outer to the skull. So let's talk about the three different types. So the first pathology we have is caput succedaneum. I don't even know how to pronounce that. Succedaneum. Anyway, this is due to edema or a hematoma of the scalp that is going to be occurring secondary to vacuum extraction. But this specific pathology is located above the periosteum, and it can cross suture lines and it resolves spontaneously without treatment. So your caput succedaneum is located above the periosteum. Okay, so this is the bone, this is the periosteum, this is the gallia aponeurosis, this is the skin. So this is happening in between the gallia aponeurosis and the periosteum. And these two layers are not connected to each other. So this blood can cross suture lines. Okay, it can cross suture lines. And it's not going to be a major bleed. These are minor bleeding episodes here. The cephalohematoma is essentially due to a hematoma formation below the periosteum and above the bone. So this time, when we talk about cephalohematoma, we're talking about a bleed not in this area, but rather in this area here. And the periosteum and the bone, they're connected to each other. So this bleed cannot cross suture lines, okay? It usually resolves spontaneously. You don't need treatment. It's not a big bleed. But the patients, when you leave the hematoma, just leave it. When that hematoma starts to break down, that's going to release quite a lot of jaundice. So the patients may get jaundice if they have large hematomas. And just for clinical help, usually these hematomas are found over the parietal bone or the occipital bone, and usually they're described as being hard. Believe it or not, they're usually hard, not soft, hard. And then the most important one to remember is the subgaleal hemorrhage. So this is bleeding into the subgaleal space between the periosteum and the gallia aponeurosis, okay? So it's between these specific areas. Just give me 1 minute, I think I've made a mistake. Anyway, it's between, I think the caput succedaneum, I think this is actually located in this space. Apologies, I think this is a mistake here. It says located above the periosteum, but I think it's located above the gallia aponeurosis. So I think that's a mistake, apologies. Whereas your subgaleal hemorrhage is located between the gallia aponeurosis and the periosteum in this space here. And the most important thing to remember about this is that this is due to bleeding and injury from the emissary veins, and it's due to traction during delivery. And here you're going to be looking at a fluctuant mass that can shift and cross suture lines. And this subgaleal hemorrhage is going to be extending, it's going to be growing, okay? And it even extends from the orbital ridges anteriorly to the nape of the neck posteriorly, okay? And it can hold up to 40% of neonates' total blood, so this is an emergency, essentially. It can result in significant volume depletion, it can result in hemorrhagic shock, so the treatment will be mainly revolved around volume resuscitation and coagulopathy correction, okay? So just to be clear, because I did make a slight mistake, the caput succedaneum is located here. The subgaleal hemorrhage is located here, and then your cephalohematoma is located here. If you're looking at a rapidly increasing mass covering a large part of the skull, it's fluctuant, it crosses suture lines, the patient is unstable, you're talking about your subgaleal hemorrhage. If you have a smallish mass that is crossing suture lines, maybe you're talking about your caput succedaneum here. And then if you're talking about a non-fluctuant hard mass, usually located in the occiput or the parietal areas, maybe you're talking about your cephalohematoma. So as you can probably tell, I'm still struggling with those a little bit, but there you go. So let's talk now about congenital hypothyroidism. So congenital hypothyroidism is a thyroid hormone deficiency in the neonate. It's often asymptomatic at birth, and that's due to the transplacental transfer of maternal thyroxine, okay? So you won't be seeing the signs and symptoms of thyroid hormone deficiency at birth. Most commonly, it is due to thyroid dysgenesis, okay? Especially in the United States, okay? i.e. the thyroid is malformed, and this is often associated with ectopic thyroid as well. So patients with like lingual thyroid, they often have major thyroid dysgenesis as well. Other things could be thyroid agenesis, so just a complete absence of the thyroid, iodine deficiency, which is actually the most common cause in underdeveloped countries. Maybe it's due to a dyshomogenesis, okay? Maybe so it's a problem with the hormones in the mother that causes problems in the hormone, the thyroid hormone production in the fetus. And it can also be due to a transfer of maternal antibodies, okay? So maybe the mother has Hashimoto's disease, and maybe some of the antibodies, the anti-TPO antibodies cross the placenta and start to attack the thyroid in the fetus. In terms of your history and physical examination, as I said already, usually asymptomatic at birth. One of the early signs that you should look out for is a delayed passage of the meconium, and that's due to a decreased intestinal motility, which you know is a sign of hypothyroidism. Manifestations after the maternal thyroid hormone decreases could be lethargy, hypotonia, a large protruding tongue, i.e. macroglossia, umbilical herniation, enlarged fontanelles, constipation, jaundice, pale dry skin, and eventually intellectual disability. And this disease, when it causes intellectual disability, in the past it used to be called cretinism, but I don't think this is a term that is used anymore. Regarding your diagnosis, newborn screening is mandatory, okay? So we screen the fetus for TSH levels, and this is done at 24 and 48 hours after birth. Why? Because we can't see the signs and symptoms of hypothyroidism, so I have to screen for it. If the patient has an elevated TSH levels, that's indicating to me that I have a primary thyroid hormone problem in the fetus. How do we treat it? Very, very simple, levothyroxine, okay? It can be co-administered with soy, calcium, and iron due to a decreased absorption that can help the absorption. And unfortunately, if the patient is untreated or if the treatment's delayed, this can actually cause neurocognitive dysfunction, but also growth retardation as well. Just looking at congenital hypothyroidism, we do have the 6 Ps, which are really nice to remember. Pot belly, okay, so the patient often has an enlarged belly, and they often have a protruding umbilicus. So I always think pot belly with a protruding umbilicus. It's kind of like two things that look alike, I guess. They are pale, they have a puffy face, which is a sign of hypothyroidism generally, even in adults. Protruding tongue, macroglossia, and poor brain development. All right? But if we give our testing early on, we find an elevated TSH, we give levothyroxine early on, we can prevent this from happening. Now, we're going to be discussing benign neonatal rashes, okay? These are not so high yield, but they are quite confusing and there is a lot of overlap between them. But let's try and go through them and make some sense of them. So we have erythema toxicum neonatorum. The onset of this specific disease is usually within the first 3 days of life, and it presents as an erythematous pustules on the trunk and proximal extremities. We don't need to do any management for these patients. It should resolve within a week. Okay, so erythematous pustules on the trunk and extremities in the first 3 days of life. Watch and wait. We also have milia. So milia is present at birth. These are little white firm papules usually found on the face. I would 100% go and have a look at some pictures of this. And again, they should resolve within a month, so we can just observe this patient, okay? In terms of milia rubra looks a lot like milia, but instead of being white firm papules, they're usually erythematous papules. And these are not present at birth, but they do present after birth, okay? So they're not present at birth. Usually these erythematous papules are found on the areas where we have a lot of sweat ducts, because the pathophysiology of this is that we have occlusion and blockage of eccrine sweat ducts, usually in the setting of increased heat. And milia rubra is something that can be seen in adults and children as well. The main prevention of this is to prevent overheating, okay? And in terms of treatment, topical corticosteroids can help relieve the blockage of the eccrine ducts. We also have neonatal pustular melanosis. This is present at birth, and it presents with a diffuse non-erythematous pustules that evolve eventually into hyperpigmented macules with a scale, okay? And it can involve the palms and soles, so the big differential diagnosis there is congenital syphilis, okay? With neonatal pustular melanosis, you're mainly going to be doing observation because the pustules should resolve within days. Unfortunately, the hyperpigmentation doesn't go so quickly, it takes months to resolve. But it's a fairly harmless pathology. And then finally, we have neonatal cephalic pustulosis, which is essentially just acne in the newborn. Usually occurs around 3 weeks of age, and it presents with erythematous pustules and papules on the face and the scalp only. In terms of management, observation. It can take weeks or months to resolve, so we can give topical corticosteroids and ketoconazole if it's very, very severe. Great, now we're going to be talking about neonatal abstinence syndrome. So neonatal abstinence syndrome is essentially the withdrawal symptoms that we get in the neonate that are born to mothers who had narcotic dependency during pregnancy. So maybe the mum was an IVD user and the heroin and the opioids, they cross the placenta, they cause desensitization in the neonate. So then when the neonate is born and they no longer get blood from the mum that's got opioids in it, they start getting the withdrawal symptoms. Newborns at high risk include those born to females with poor social support, poor mental health, and no prenatal care, and IVD use, and even infections as well. Or in mothers requiring chronic prescription opioids. Maybe the mother has got some kind of chronic pain syndrome where she requires opioids, okay? But generally speaking, you're looking for low economic young females with an IVDU history. In terms of your history and physical examination, it usually presents more than 24 hours after birth. That's essentially when the maternal transplacental opioids have then exited the bloodstream of the fetus, or of the baby. It may present earlier, especially if the mother was using heroin. That's because the heroin specifically has a very short half-life, so the baby's going to start to get withdrawal symptoms way earlier. The symptoms that you should be on the lookout for are central nervous system symptoms, including shortened sleep-wake cycles, hypertonia, tremor, and suck-swallow incoordination. Other autonomic symptoms that you should be looking out for is diaphoresis, sneezing, and yawning. Just from my experience of solving questions for neonatal abstinence syndrome, they tend to like the yawning one and the hypertonia one. Other symptoms could include irritability, vomiting, and diarrhea. But if you're looking at a woman who has maybe poor social economic status, history of IVDU, baby is born and 24 hours after birth starts to get tremoring, diaphoresis, yawning, and hypertonia, I would be considering neonatal abstinence syndrome. So in terms of our diagnosis and treatment, it is a clinical diagnosis, but we can confirm this if we want. We can do confirmation with drug testing of umbilical cord, urine, and stool. This can literally just tell me whether there is actually opioids or other drugs within the circulation. In terms of treatment, mild withdrawal is treated with a non-pharmacological approach, okay? Quiet environment, swaddling, small frequent feeding. But severe withdrawal, unfortunately, we've got to treat it similarly to how we treat adults with withdrawal. Morphine, methadone, and then eventually we will taper that off and provide support. So that's everything for neonatology. I hope that was helpful. I do apologise for the small hiccup that we had with the scalp hematoma disorders, but I hope that that was helpful for you anyway.